Hello friends, today we'll talk about the ABG. I know this is very important topic for the exam going students and exams are around the corner. So I thought let's do it for the students. So we all know ABG interpretation is one of the most powerful bedside tools we have in critical care. It condenses the physiology of the lungs, kidneys and circulation into a single page. It's just not about the numbers, it's about understanding how the body is compensating and what is it trying to tell us. So to learn all about this, allow me to share my slides. Yes. So, as you know, I'm Dr. Bharat Jagiasi, and you're listening to this on my YouTube channel. I would request you all to subscribe on my channel and also share with your friends these talks to spread the knowledge. So, when you talk about the ABG, so we need to understand why do we order a blood gas analysis. So, we all know it's a vital role in monitoring of post-operative patient receiving oxygen therapy, those on inotropic. So, ABG is ordered with the purpose. We used to monitor oxygenation, ventilation, acid-base balance, particularly in all these kinds of the patient. Remember, the APG reflects how the patient is doing physiologically, not just how they look clinically. So it's very important to look into this. And we talk of the basic physiology of the acid-base balance. So our body has a literally narrow pH window that's somewhere around 7.35 to 7.45. A small deviation from this range can have a profound effects on the enzyme activity and the cellular function. And the two main defenders of this range are the lungs and the kidneys, and the two mechanisms which they regulate with the pH is the respiratory and the metabolic. If the pH is less than 7.35, it's said to be acidic, and the blood pH is more than 7.45, it's said to be alcoholic. So when you talk about the respiratory buffer, so carbon dioxide is the normal byproduct of cellular metabolism. It's not just a waste gas, it's an acid in disguise. As ventilation changes, so does the pH. So when acidosis sets in, the body hyperventilates to blow off carbon dioxide. But alkalosis develops, it slows down breathing to retain it. This is the body's first and the fastest line of defense. So, as you understood rightly, the blood pH changes according to the amount of carbonic acid in the body, that is depth, which is dependent on the depth and rate of the ventilation. So, as the blood pH decreases, carbon dioxide is exhaled. As the blood pH increases, carbon dioxide is retained. And how does it happen? If you look into this, in case of acidosis, if the pH has gone down, it stimulates the brain and arterial receptors, which increases the respiratory rate. As a result, blood CO2 goes down, blood bicarbonate goes down, and the pH increases, and the acid-base homeostasis is restored. If the pH is gone on the higher side, that is alkalosis, it stimulates the brain and arterial receptors, and the respiration rate goes down. Blood CO2 goes up, blood bicarbonate goes up, and the pH comes down, and this is how the acid-base balance is restored. So when you talk about the renal buffer, the kidneys always take their time, hours to days, because they are precise. The kidney secretes hydrogen ion and reabsorbs bicarbonate in response to the metabolic acid formation. So they retain bicarbonate when acid accumulates and excrete it when alkalosis occurs. The slower mechanism ensures long-term balance, especially when the respiratory system is overwhelmed. How does it do it? It does by the three main functions, that is excretion of hydrogen ion by tubular secretion, reabsorption of filtered bicarbonate ions, and production of new bicarbonate ions. What happens when the metabolic regulation fails? This is what we are looking into. So either we have the metabolic acidosis or the metabolic alkalosis arises when the fine balance breaks. In acidosis, we either lose bicarbonate or accumulate acids. In alkalosis, we lose high hydrogen ion or retains too much of base. So each mechanism points towards a specific underlying disease process, and our job is to trace it back to its source. And this is why ABG is very important. It's not just about the numbers, as I said it before. It makes the job easy to trace it back to its source so that we can correct the disease precisely. So we have two major components of ABG, that's oxygenation status and also the acid-base balance. So an ABG tells us two things. And what we start about, if we look into the oxygenation status, what we do is we always look into the PF ratio. So don't stop with the PaO2 and the PF ratio. Always also look into the alveolar arterial gradient, that is AA gradient, which is calculated by subtracting arterial oxygenation from the alveolar oxygen. It's a useful parameter for narrowing the differential diagnosis of hypoxemia, and normally it is somewhere around 5 to 25. So how do we calculate it? So always look for the hypoxemia. If there's no hypoxemia, of course, we have the adequate oxygenation. If there's a hypoxemia, look for the AA gradient, that is alveolar arterial gradient. If the alveolar arterial gradient is not elevated, the hypoxemia is due to hypoventilation or the low FiO2 or low PO2. If the AA gradient, that's alveolar arterial gradient, is elevated, look for the alternate cause and always look into the PO2 in response to the supplemental oxygen. If the response is good, we are looking into the VQ mismatch. If the response is not good, we are probably looking at the shunt. And this is what turns a good intensive into a great one when we start seeing beyond numbers into the mechanisms. So when we talk about the basic terminology of the acid-base status, acidemia and alkalemia describe the pH, and acidosis and alkalosis describe the process behind it. So acidemia and alkalemia depends on the normal range, and the acidosis is about the abnormal process, whether the increase in the hydrogen ion by increasing PaCO2 or decrease in the hydrogen by reducing the PaCO2. So as we understood, it's crucial to distinguish between them because patient can have acidosis and alkalosis at the same time, and the pH might still look deceptively. So how do we, what are the components we look into? So we look into the pH, PO2, PCO2, bicarbonate, and anion gap. And if you look into the normal range, these are the normal ranges of all the components. pH is somewhere around 7.35 to 7.45, PO2 around 80 to 100, PCO2 35 to 45, bicarbonate 20 to 26, and anion gap 10 to 14. So approaches towards the management of the ABG interpretation, approaches towards the ABG interpretation, we have two schools of thought, the traditional bicarbonate-based approach and the Stewart physiochemical approach. Both aims to explain the same phenomena, how ions and gases interact to maintain the hemostasis, and which you use is key in consistency. So let's understand how do we do it. So when you talk about the steps of interpretation, always look into the validity, then finding out the acidemia or alkalemia. Step 3 is looking for the which is the primary disorder, respiratory or the metabolic. If respiratory, is it acute or chronic? Then if it's a primary, once you diagnose with the primary disorder, always look for the compensatory response if it's there or not there. And then if it's there, is it a mixed disorder? What exactly it is? Of course, then look for the metabolic components, anion gap, delta gap, osmolar gap. This is what we all look into. So let's go into the step 1. When you talk about the validity, never interpret an invalid sample. The Henderson equation helps verify internal consistency, and the numbers don't fit physiologic norms. It's not the patient, it's the sample basically. So this is the Henderson equation, what we look into, and once we have calculated, this 40's number comes in, which as per the equation has been looked into. So the number of hydrogen ion, what we calculate is 40, and pH should be somewhere around 7.40. So if you look here, this corresponds, and this is all this ABG is valid. Supposedly, if you calculate the hydrogen ion and the number was around 63, it should correspond to the pH of 7.20. And if we can see this, it tells us this ABG is valid and it's not a bogus one. So let's calculate it. So there's a 22-year male evaluated for weakness and weight loss, and this is what the numbers are. So I need to calculate the hydrogen ion, that is 24 into PCO2 by bicarbonate. So it's coming around 28.8. And when I look into it, 28.8, the pH should be somewhere around 7.6, somewhere around 7.5 to 7.6, and the pH is 7.32, so the ABG is invalid. Now, same here, I have calculated hydrogen ion as per the calculation, as per the formula, it's coming to somewhere around 30.17. When it's come to 30.17, pH should be somewhere around 7.5. pH should be 7.5, 7.49. So this ABG is valid. This is how we look into the validity of the ABG by calculating the hydrogen ion and looking at the corresponding pH in this equation, this chart. So the step 2 is whether it's acidemia or alkalemia. So always starts with the pH. If it's below 7.35, we are dealing with acidemia. If it's above 7.45, we are dealing with the alkalemia. So once you know the direction, you can trace whether the cause is respiratory or the metabolic. So when we look into the acid-base disorder, it's a change in the normal value of extracellular pH that may result when renal or respiratory function has failed. So pH is dependent on, we all understood, on the PCO2 and the bicarbonate ratio, and to maintain the normal pH, PCO2 and bi ratio has to be constant. So the initial change is the primary disorder, and the secondary response is called the compensatory disorder. So now we look into the step 3, whether it's a metabolic or the respiratory component. So once we find out, step 1 is to look into the ABG is valid or not. Step 2, we looked into whether there's an acidosis or alkalosis. Now, if the acidosis or alkalosis, then which one is the primary component, respiratory or the metabolic? So if the pH and pH2 are both abnormal, look for the direction. Both change in the same direction, it's a metabolic component. Both changes in the different direction, it's a respiratory component. So whenever there's a change in pH, always look for the PaCO2. So if the PaCO2 and the pH are in the same direction, that is, both are if increasing or decreasing from the normal value, it's a metabolic component. If the pH and PaCO2 are going in opposite direction, one is going up, that is increasing, second is going down, that is decreasing, or vice versa, it could be the respiratory, it is a respiratory component. So if respiratory component, just let me clear this for you. Is it acute or chronic? This is what we have to look into. So the detailed history of patient is very much important, and the speed of change differentiates acute from the chronic. So in chronic respiratory acidosis, for instance, the kidneys have had time to retain bicarbonate, so pH doesn't fall as sharply. So always read the numbers in the context of the time. So calculate what is the difference of the hydrogen ion, what is the difference in the PaCO2, and look into the ratio of delta H to delta PaCO2. So if the ratio is less than 0.3, it's a chronic. If the ratio is more than 0.8, it's acute. And the ratio somewhere in between 0.3 to 0.8, it's called as acute and chronic. So understood, the step 1 is validity. Step 2 is look for the pH, that is acidemia or alkalemia. Step 3 is look whether respiratory component or the metabolic component. And if it is a respiratory component, you have to look into whether it's chronic or acute. How do we do it? Look into delta H and delta PaCO2, the difference in hydrogen ions and difference in PaCO2. If it's less than 0.3, it's chronic. If more than 0.8, it's acute. If somewhere on 0.3 to 0.8, it's acute on chronic. Now here, what we look into is the compensation. The body always compensates in the same direction as the primary disorder. So if there is a respiratory alkalosis, the primary defect is the decrease in the carbon dioxide and rise in the pH. That is, the patient will try to, now patient is hyperventilating, and this is usually seen in the CNS disease, hypoxia, anxiety, patient on the mechanical ventilator because he's anxious, or the tube is irritating when the patient on progesterone therapy, and also in the sepsis. And what we see in the respiratory disorder, the primary defect is an increase in the carbon dioxide and a fall in pH. Maybe there's a hypoventilation, and the causes are inhibition of the respiratory center, that's the drug like narcotics, alcohol, sedatives. There's a CNS lesion which has got the GCS down and suppresses the respiration. Nerve damages like high spinal cord injury, which is paralyzed, which has weak our respiratory muscles, GBS, or myasthenia gravis in the botulism. So the primary, what we are looking into the compensation. So body always compensates in the same direction as the primary disorder, a crucial concept. So compensation exceeds or falls short of expectation if it's a mixed disorder. This step separates true physiology from the pathology. So how does it compensate? So suppose there's a decrease in the pH, we all know it's a metabolic acidosis, and of course the bicarbonate will be less. So how body will try to compensate is by decreasing the carbon dioxide so that pH is balanced. If it's a metabolic alkalosis, the pH will go up, bicarbonate will go up, and the body will try to compensate by increasing the PaCO2. So in each case, the compensatory changes are in the same direction as the primary changes, and this is known as same direction rule of compensation. But this is what we need to understand. So the compensation occurs in the same direction. Again, if there's take one more example, if it's a respiratory disorder acidosis, we expect PaCO2 to go up in the primary change, and the compensation will happen by increasing the bicarbonate. In the respiratory alkalosis, PaCO2 is down, the compensation will happen by decreasing the bicarbonate. So the same direction rule of compensation applies over here. Now, when we look into this, we also look whether it's an appropriate compensation or not. So why do we calculate check for compensation? Because the useful in differentiating from mixed disorder. If expected, actual change, disorder is very simple. If the actual change is more or less than the predicted, it's a mixed disorder. And as we understood, compensation follows the same direction rule. If the changes are in opposite direction, always think of the mixed disorder. So and now we talk about the respiratory compensation. So respiratory compensation, it occurs very rapidly as we understood. Take few hours to peak, and it starts within few minutes, and differentiation in between the acute and chronic. For example, in metabolic acidosis, there's hyperventilation, small breathing, more deep and rapid, and wash away carbon dioxide. Likewise, in metabolic alkalosis, there's hypoventilation. Metabolic compensation, we all understood it takes time to initiate and compensate, approximately 2 to 5 days, and is initiated by the kidney, and the bicarbonate are the limiting main factors. So how to calculate the compensation? So in metabolic acidosis, if we have to calculate, we all have to remember this formula for that is Winter's formula for the examination to calculate whether the compensation is right or not, whether there's a mixed disorder. So in metabolic acidosis, we always expect pH to go down, bicarbonate to fall. So what would be the compensation? Compensation would be decrease in the carbon dioxide. So how much? So we calculated by this formula. PCO2 will be 1.5 into bicarbonate plus 8 Winter's formula. So these formulas you have to remember in case of the disorders. In the respiratory acidosis, we have the acute and chronic. In the respiratory alkalosis, we have acute and chronic. While in the metabolic, we have just one formula. That is, for the acidosis, one formula, alkalosis, the second formula. So this is the case what we are looking into. 62-year-old male with COPD presents with breathlessness. pH is 7.25, PaCO2 80, PaO2 39, bicarb 38, SO2 58, sodium 139, potassium 4.1, and chloride 89. First, we look into the oxygenation status. If you look into the PaO2, that is atrial gradient, the AA gradient is somewhere around 11. Normal, we all know is 5 to 25. So hypoxia is due to either hypoventilation or decrease in the PO2. So here the hypoventilation is the problem. Assuming the ABG is valid, we look for the Henderson's equation, that is delta H and delta PO2 is somewhere around 0.25, that is less than 0.3. That means it's a chronic one. Now we calculate the metabolic compensation. Metabolic compensation with as per the formula, we look into it. So expected change would be somewhere around 16. So that would be bicarbonate 24 plus 16, and which is correct. So this is a chronic respiratory acidosis. So of course the pH is less. It's an acidosis. You look for the primary disorder looking into the pH, so what direction it is. So again, it's a respiratory disorder. We look into the pH and the PaCO2. If they both are rising or both are increasing, here it's an opposite direction. So one, because PaCO2 has gone up and pH has gone down, it's a respiratory disorder. Now ABG is valid. We calculated. Now, because it's a respiratory disorder, we need to look into whether it's acute or chronic. So we looked into the delta H into the delta PaCO2. It's come around 0.25, less than 0.3. That means it's a chronic one. Now calculate whether the metabolic compensation is right or not, or it's a mixed disorder. So of course, when there's a PCO2, when there's an increase in the PCO2, so the compensation is always in the same direction. Bicarbonate will try to go up. So the expected change is somewhere around 16, and normal is 24. So 24 plus 16 is 40, and this is what we see exactly over here, somewhere around 30. This is why it's a simple chronic respiratory acidosis. Now, to look into the cause, as we discussed earlier, we look into the alveolar arterial gradient, which is coming to somewhere around 11. Normal is 5 to 25. So if it's alveolar arterial gradient is normal, that means it's an hypoxia due to hypoventilation. So this is how, once we diagnose, it's a chronic respiratory acidosis, and it's because of the hypoventilation. Now we look into the mixed disorder. So if the either pH or PaCO2 is normal, there's a mixed and metabolic respiratory acid-based disorder. So mixed metabolic and respiratory acid-based disorder could be seen in both the cases. It could be acidosis or alkalosis. If the pH is normal, the direction of change in PCO2 identifies the respiratory disorder. If the PCO2 is normal, the direction of change in pH identifies the metabolic disorder. So if there's a normal pH, always look for the PCO2 direction, and it tells you what the respiratory disorder is. The PCO2 is normal, then look for the change in direction of pH. It identifies the metabolic disorders. So the metabolic alkalosis, the primary defect is, of course, we all know increase in the bicarbonate in the metabolic and the rise in the pH. And the causes, we are aware of it. It could be the removal of the gastric secretion. It could be the diarrhea, mineralocorticoid, excess diuretics. This is all what we look into, and always send the spot urine chloride to see if the patient is salt responsive or not. If the spot urine chloride is less than 20, that means patient is salt responsive. Most probably the causes are vomiting, nasogastric suctioning, or the wasting because of the dichloride wasting based on diarrhea and diuretics. If the spot chloride is more than 20, patient is salt responsive. The most common diagnosis is the mineralocorticoid excess, milk alkali syndrome, and sodium and magnesium deficiency. So we'll do these cases a little later. Now, how do we approach towards the metabolic alkalosis? How do we look into it? So always, whenever there's a metabolic acidosis, once you diagnose it, always also try to look for the anion gap. So the anion gap is just isn't a formula; it's a window into hidden acids based disorder. Widened gap points towards the unmeasured anions like lactate, ketones, or toxin, and always correct it for albumin. Otherwise, you might miss a subtle pathology. So HAGMA is high anion gap metabolic acidosis, and NAGMA is normal anion gap metabolic acidosis. Whenever there's a high anion gap metabolic acidosis, always look for the delta ratio and also the osmolar gap. When there's a normal anion gap acidosis, look for the urinary gap. If urinary gap is positive, is the renal cause of metabolic acidosis is what more commonly seen. If it's negative, then we are looking for the extrarenal or the GIT gastrointestinal causes of the metabolic acidosis. So again, because I'm moving towards a different part of this, I'll revise it again. So whenever we have an ABG with us, the step one is always look for the validity. Step two is look for whether there's an acidosis or the alkalosis. Step three is look whether there's a primary metabolic component or the respiratory component. Step four is, as per the calculation, if it's the metabolic component, the formulas are very simple for the acidosis and alkalosis. If it's a respiratory component, the formulas to look for the mixed disorder or the compensations are different for the acute and chronic diseases. So always look for the mixed components. Once you diagnose the metabolic acidosis, then you look whether it's a high anion gap metabolic acidosis or the normal anion gap metabolic acidosis. If it's high anion gap metabolic acidosis, calculate the delta ratio and the osmolar gap. If it's a normal anion gap metabolic acidosis, calculate the urinary gap. If it's positive, most probably it's a renal cause. If it's negative, most probably it's a non-renal cause and coming from the gastrointestinal tract. So as understood, that identify the cause of the metabolic acidosis by determination of the anion gap. And how do we calculate the anion gap? It's a gap between the cations and anions. The formula is this: sodium minus chloride plus bicarbonate. That sodium is a cation and anions are chloride plus bicarbonate. So the normal anion gap is somewhere around 10 to 40. And increase anion gap occurs when there's an increase in cations and more commonly a decrease in anions bicarbonates. So anion gap will go up either when there's an increase in cations or when there's decrease in anions. So cations are mostly sodium, calcium, magnesium, and anions are mostly bicarbonate, chloride, and unmeasured ones are the protein, lactate, ketone, phosphates, and sulfates. So we all understood this increase anion gap metabolic acidosis is what we are looking into, characterized by the low bicarbonate or the increased anion gap. And the causes could be, we remember this by the mnemonic called as mud piles. So it could be the methanol, uremia, decayed ketoacidosis, parahaldehyde, isoniazid, lactic acidosis, ethanol toxicity, rhabdomyolysis, salicyclase. So this could be the causes of the increased anion gap metabolic acidosis. When we look into the normal anion gap metabolic acidosis, so this is what we look into: hyperalimentation, acetazolamide, renal tubular acidosis, diarrhea, uretropelvic shunt, post-hypercapnia, spironolactone. So these are the causes of the normal anion gap metabolic acidosis. Now the step 8 would be to look for the delta ratio and then followed by the osmolar ratio, which define your diagnosis. They reveal whether two metabolic processes coexist, such as decay with the concurrent normal gap acidosis or toxin-induced disorder. This is where the interpretation becomes an art, not just an arithmetic. So delta ratio is to be calculated. Once you find the anion gap, it's minus 12 divided by the delta bicarb. That's a 24 minus the actual bicarb. So delta anion gap divided by the delta bicarb. This is how we look into the delta ratio. So if the delta ratio is less than 0.4, it's a hyperchloremic NAGMA. If it's 0.4 to 0.8, it's hugma plus nagma. If it's 1, seen in decay due to urinary ketones. 1 to 2, pure hugma. If more than 2, pure hugma due to the metabolic acidosis. Now we look into the osmolar gap. That's major osmolarity minus calculated osmolarity. So major osmolarity can be measured from the serum blood sample, and this is what the calculated osmolarity is calculated as by having the values of sodium, blood urea nitrogen, and HGT. And the normal osmolar gap is somewhere around less than 15. So it is elevated in lactic acidosis, methanol or ethylene glycol poisoning, a patient having an excessive alcohol, and when we are giving mannitol. So when there's an approach to the metabolic acidosis. So whenever there's a metabolic acidosis, look for the anion gap, whether normal or whether high anion gap or the normal anion gap. If the anion gap is high, look for the delta ratio and the osmolar ratio. If the anion gap is normal, calculate the urinary gap, and if positive, it is a renal cause. If negative, it could be the if it's negative, it could be the extrarenal causes. Now just go through the cases and let's see how does it goes. So this is 32-year-old male with known case of diabetes mellitus, presence of vomiting, lethargy, and altered sensorium. So what we're looking here is the patient having an SGT of 750, urine ketones 3 plus positive, BUN 38, albumin 2.5, and the serum osmolarity 344. So pH is somewhere around 7.17, PaCO2 15 millimeter of mercury, PaO2 is around 125 million mercury, and bicarb is 5, lactate 2. So this is where this case ties it all together. So if you look into this, I'll go ahead. The PC of what initially the step 1 is to look for the validity of the ABG. So using the Henderson equation, you will find whether the ABG is valid or not. So this ABG is valid. Step 2 is look into the pH. So pH is less than 7.35. There is an acidosis. Now again, whether the respiratory component and the pH component are the same direction or not. So they are not. It's a metabolic acidosis. Look for the compensation. So because it's a metabolic acidosis, so always there's a one formula. So this is expected change in the bicarb. It's a primary metabolic acidosis. Now it's a metabolic acidosis. We'll be looking for the anion gap. So the anion gap is somewhere around 36. It's a high anion gap. Also look for the delta ratio, which is 1.2. So this is high anion gap, metabolic acidosis. And looking into the osmolar gap, it's a high osmolar gap. So it gives us the diagnosis of diabetic ketoacidosis due to lactic acidosis. So this is how a single ABG not only gives you the number and the physiological status of the patient, it also helps you in giving the diagnosis pertaining to the history of the patient. So it's a very simple way of coming to the conclusion of this whole story. So ABG tells the story of how the body fights to maintain balance, how our task is to read that story with clarity and empathy, and always correlate numbers with the patient at the bedside, because physiology and not printout saves lives. Thank you very much.